Hi, everybody. I hope you can hear us clearly. I'm going to start with an introduction and then hand over to Judy. So I'm Debbie from the Academy for Adults with Autism. Welcome and thank you for joining the session this evening. The topic is behavior and the role of medication. If you have questions, please feel free to, after Judy's presentation, unmute yourself and ask. We'll have to take turns doing that if there are lots of questions, or post your question in the chat box. If there is no time to address your question, please note the link that we've put in the top box in the chat, and that is for a Google form for questions for our panel discussion on the 4th of May, Tuesday evening. So we hope you'll all join us for that. The series of talks came about as a result of numerous inquiries that our nonprofit organization is receiving from parents, caregivers, and those supporting persons on the autistic spectrum, especially in their home and living environment. Let us bear in mind that each person within the autism spectrum is an individual with their own experiences, their abilities, and their own unique support needs. There are many layers and complexities that need to be considered. It is very easy to feel overwhelmed as a parent and supporter, and we hope you will find these sessions valuable in understanding and helping someone in your life who is on the autism spectrum. Thank you to people on the autistic spectrum who explain their experiences to us and who assist us with understanding and helping others. This input we value highly, and we regard this as a very important part of the constant learning, adapting, and networking that must take place. Judy Bentley is a psychiatrist and trainee chicken farmer currently living and working in Plettenberg Bay. Judy graduated from UCT with a medical degree in 1993 and subsequently spent some time working and living in the UK and Zimbabwe. She returned to South Africa in 2000 and obtained her fellowship and master's degrees in psychiatry. After registering as a specialist psychiatrist, she worked in the state health system, working exclusively with people with intellectual disability, some of whom were also diagnosed with autism. Judy's interest in autism specifically began when her friend's son was diagnosed with autism, a diagnosis she had missed herself due to woefully inadequate training in the area. This led to her passion to learn more about autism and an attempt to introduce more training into the undergraduate and postgraduate medical and psychiatric curricula to ensure that doctors and psychiatrists of the future would not make the same mistake she had made. Since moving into private practice in 2011, Judy has learned more about autism from her patients than she has ever been able to learn from the scientific literature. And although she now treats patients with all psychiatric and psychological problems, autism remains a special area of interest. I'm going to hand over to Judy now. Thanks very much, Judy, for giving of your time and for putting so much care into your presentation.
Pleasure. Okay, I hope everybody can hear me all right. A little bit of challenge in Plettenberg Bay with internet connections, but hopefully it will be fine. Okay, yeah, so as Debbie said in my introduction, I've learned most of what I actually know about autism from my patients. There really was very little training when we did my medical, and really when I was doing my psychiatric, diagnosed with autism when she was in her 20s. And she's very happy for me to give a name, Deborah Can. She's also said that anybody can always contact her afterwards. So she wrote this poem, and I thought it was very pertinent to talk today. Whoops, there we go. Everybody sees me, I look normal. They don't know how much strength it takes to work full time, do my chores, or go to appointments. They can't see inside my brain with its different structures and chemicals. They don't understand I have no filter for incoming sensory traffic. They don't understand how deeply I feel my own and other people's pain. They don't understand that I only feel safe at home. They don't understand that my life is a tightrope. One misstep and we lose our balance. We become disorientated. We melt down, sick. Obviously, when one's giving a talk about challenging behavior, things that a person does, behavior, that those supervising their activity in any given setting find challenging. That definition of challenging behavior can be just about anything that a carer finds challenging. It's refusing to follow instructions, throwing things, the person hitting themselves or others, or in any way being disruptive and not following the expected plan for the day. This is often particularly problematic in group or school situations, but it can also be problematic and sometimes even dangerous in the home environment. If you analyze the phrase itself, it is quite, well, someone's looked at a person performing and decided that activity in that place at that. But challenging behavior usually is serving some kind of function for the individual with autism. It can indicate a means of communication, or it can be a normal autistic behavior for that person with autism, that to enable them to self-regulate, although it's not acceptable to the people around them, or it can be an expression of discomfort or agitation, which can be either internal, so in other words, internal discomfort, or that something around them is just too challenging for them to comply in the situation. Okay. So one of the problems when preparing this talk is that the autism spectrum is such a huge spectrum. We're basically lumping together people that have superior intellect, those with normal intellect, those who have intellectual disability. We're lumping together people who are fully verbal, those with limited expressive or limited comprehension, and those who are nonverbal. We're lumping together people who have sensory issues. They're either sensory seeking, sensory avoidant, or combination of both. We're lumping together people who can mask their autism well, which I kind of call level 1. In other words, they theoretically don't need that much support, and those who can't mask their autism. We're also lumping together those who've been severely traumatized, either by the way that they have been treated, or just through traumas that all of us experience, and those who've been very well supported from their date of diagnosis. But obviously, in the interest of brevity, I need to kind of generalize, and I'll try to make this as useful as possible for everybody rather. So when someone presents with a new behavior that is considered challenging, so not a long-term behavior, but when there's been a change in behavior, I run through the following checkpoints to try to identify possible causes, and I'll come back to this later. But the first thing with a new behavior is there any new medical condition or source of pain? And especially if someone is nonverbal, that can be quite difficult to pick up. But common things are problems with the teeth, with the ears, or bowel related. Obviously, it can be absolutely anything. Has there been any change of medication? Okay, recently, because medication of any form, doesn't have to be psychiatric medication, can cause side effects which can cause changes in behavior and discomfort to the individual. Changes to routine and the environment, and we'll talk more about that later. Any recent trauma, it's not always known by the carer. And is there any possible comorbid psychiatric condition, such as anxiety, depression, or psychosis? Obviously, ADHD also comes in here, but that would be a more long-standing thing. So, like I said, below long-standing behaviors are usually an indication that the behavior is part of the autism diagnosis, or it's ADHD related or anxiety related. Anxiety is often a very long-standing thing, or there is a poor environment individual fit, or people are just trying too hard to make the individual fit the environment. Other causes for changes in behavior after we've excluded those causes are autistic overload, or somebody that's developed a new strategy for self-regulation. Okay. So what is autistic overload? And yeah, I'd also like to say that I actually got a lot of this from the website Neuroclast, which is written by people with autism. But it is sort of a general information that is out there. But I found it very useful to actually read what people with autism say about their own problems. So autistic overload can take three kind of forms: autistic burnout or regressions. It's a form of sort of silent and prolonged collapse. So the mind is busy handling all the stimuli that have overloaded it, and the person can no longer focus on maintenance tasks. So it can manifest itself as difficulties with basic tasks that the person has already mastered in the past, such as talking or socializing. Can also manifest physically with headaches, nausea, muscle tension, difficulties with sleep patterns, and then more psychologically, feeling overwhelmed, feeling dissatisfied and frustrated. It can turn into depression, apathy, cynicism, feeling exhausted, irritability, and a tendency to lose one's temper. Actually, in many ways, very typical to burnout in anybody. Recognizing and intervening with burnout actually, unfortunately, does require one to reduce demands on the person with autism and try to maintain an optimal level of sensory input. Easy to say, not so easy to do. And when somebody with autism is trying to hold down a job, it can often be very difficult, and one may need to actually look at the job and try to see if there are any accommodations that can be brought in. And so autistic burnout is more of a sort of slower burnout process. Autistic meltdown is an extreme stress reaction, and I think we all know what and have seen this. It manifests itself often as a furious outburst in overwhelming situations, situations that may not appear overwhelming to the people around the person with autism, but are overwhelming to the person with autism, and can result in a complete loss of control of behavior. It can be expressed verbally with screaming, yelling, uncontrollable crying, verbal aggression, physically kicking, hitting, breaking objects, biting, or both, so verbal and physical. And then autistic shutdown is like the flip side of a meltdown. It can occur sort of short term and be quite acute, or can be a more long-term thing. So when somebody with autism has a shutdown, they literally disconnect and limit themselves to the minimum necessary to survive. They go on autopilot, may suddenly become quite mute, in other words, nonverbal, isolate even more intensely, and experience serious setbacks in previous functioning. At its extreme, it may present as catatonia, although that is a whole nother subject. Okay. So then other behaviors that can come across as challenging are socially unacceptable self-regulating behaviors. In people who are predominantly sensory seeking, this can be quite common. So yeah, they will tend to then seek out more sensory stimulation to achieve an appropriate input level for them to feel that they're maintaining balance. So some of the behaviors that can be challenging are, well, it's not really a behavior, but intolerance or indifference to pain. So now that can actually be quite dangerous. Bumping into people or objects or rubbing against them, which is obviously can be very socially unacceptable. Hyperactivity and fidgeting. Inability to estimate their own strength and hence breaking things. Refusing to wear shoes because they want to feel the sensation of things under their feet. Needing very tight clothing, needing loud noise, not being aware of other people's space, smelling objects or people, spinning and so on, and mouthing objects. And obviously some of those are really not socially acceptable. The sensory avoider tends to be kind of in a way more socially acceptable, but if they are overstimulated, then that can result in a meltdown. So sensory avoidant people will tend to hear things that other people don't perceive. So for other people, it's background noise, but for them, it is not background noise at all. For example, even things like the hands of a clock. I had one patient who was diagnosed with autism very late in life, used to come and see me when I was practicing in Newlands in Cape Town, and I had 2 clocks in my office which were not in sync. Well, actually, there were two of my patients complained, and I would have to actually take one of the clocks out because for them it was just absolutely intolerable. They could not handle the noise, even though they were very quiet. People who are sensory avoidant also tend to be very anxious about busy soundscapes. So, for example, if they're still at school during break time, lots of people running around and making a lot of noise. Going into malls, that kind of environment can be very, it's too stimulating and overwhelming. They may prefer to be in dark or low lit rooms and not enjoy bright environments, especially fluorescent lighting. May avoid swings or games that require a lot of movement. Not enjoy crowded spaces. They may have meltdowns when they're expected to travel by certain means of travel because there's too much motion. Okay, I'm just going to have to nip out and turn my lights on again. I will be back in 2 seconds. Sorry, that wasn't Eskom's fault. I have a time on my lights. Okay. Okay, and then there are all sorts of other things where sensory avoidant behavior can actually become more problematic for carers. For example, if people do not like to have their nails cut or their hairs cut, their hair cut, not liking to wear clothes at all, that can be really problematic, and having extreme sensitivity to certain odors and so on. Okay. Other times when self-regulating behavior can become socially unacceptable are rigid routines, and I think we again all know this. Routines provide people with autism with a sense of security and control. It allows them to predict certain events in the day so that they can kind of do those on autopilot, and it gives them room then to actually incorporate the things that do need to change in the day and to handle the other stimulation that is around them. It kind of gives them breathing room and capacity to cope what is beyond their control and their expectations of society. But at times, this obviously can become very problematic with the family, school, or work environment when it's not always possible to accommodate a person's routine. Sometimes the routines can also be extremely lengthy and problematic. I do have one patient whose bedtime routine can take up to an hour. And although it really helps her to go to sleep, it requires the input of the mom who is tired at night, and this is now an adult that she's dealing with, and yeah, then it can become problematic. It does sometimes help, though, to understand what its function actually is, and to try to give adequate attention to preparing the person with autism for any changes that they do need to be with the routines, and actually put some effort into those changes and not just make the demand. Okay, then stimming. Stimming is actually a natural behavior. Not only people with autism do stimming. I rock, and although I do have some autistic traits, I've not been diagnosed with autism. And yeah, it improves emotional regulation and kind of can actually help people, prevent people from going into overload in stressful situations. If you think about it a bit, it's quite easy to make the connection between some of the typical autistic stims and some of the things that neurotypical people do to help calm themselves down when they're anxious. So, for example, some of the best known autistic stims are visual stims, moving fingers in front of the eyes, staring at twinkling lights, whereas with a neurotypical person, they might enjoy having candles around them, watching trees blowing in the wind, so watching the leaves blowing in the wind. Auditory stims, making vocal sounds, snapping fingers, repeating rhythms, repeating words. Neurotypical tends to be listening to music, reciting mantras, meditation. Tactile stims, scratching, rubbing skin or muscles with hand or an external object, twirling hair. The twirling hair is definitely a neurotypical thing as well. Vestibular, moving the body. It helps sometimes if people are anxious. So neurotypical people are anxious to do some dancing, do movement, do yoga. Taste. licking objects or body parts, which can obviously be very socially unacceptable. Chewing gum. Okay, chewing gum is something, again, neurotypical people do. We also comfort eat. Olfactory stims, smelling objects, smelling people. Okay, again, socially really unacceptable, but who doesn't like a nice smell of lavender around them, or some aromatherapy oils when you're feeling very anxious? Okay. So, yeah, obviously there's a wide range of what we term challenging behavior. So it's difficult to kind of really look at ways of managing challenging behavior, but I've tried to sort of give a general overview. If challenging behavior is long-term and high frequency, like I said earlier, that usually implies that it's actually part of the autism or a longer-term psychiatric comorbidity like ADHD or anxiety. I usually advise people, if possible, allow what isn't harmful. Okay, so if you're able to, and by harmful, I do also mean socially really unacceptable. If you take your child or your adult shopping and they're going up and they're pulling on other people's hair or they're sniffing other people, it can result in an aggressive outburst from the other person concerned, and that can be harmful. So for socially unacceptable behaviors, like pulling strangers' hair, smelling or tasting objects when out, if possible, distract and try to replace with a more acceptable self-regulating behavior, okay, which I hope will kind of also come up in next week's talk. So where there are other things that people do, other stims that people do to self-regulate, try and distract and bring one of those in that are more socially acceptable than the socially unacceptable behavior. So I do try to advocate a low arousal approach where necessary, where possible, I mean. So in other words, trying to avoid situations that are likely to cause increased stress and prepare thoroughly for any changes in routine. Also work on methods of communication, as was discussed last week, to try to just get that free flow of communication, try to understand what the function of the behavior is so that you can avoid anything that is going to cause problems. With extreme hyperactivity, destructive behavior or aggression that is high frequency and doesn't respond to other interventions, then one may need medication. Okay. And I'm really not anti-medication. I'm a psychiatrist after all, but I do like to see it as a last resort, because it comes with side effects, which hopefully we'll have a little bit of time to go into. Okay, so that's kind of long-term high frequency. Then, as I mentioned earlier, if there's changes or worsening in behavior, then we need to go through that screen that I mentioned earlier. Is it a medical condition? Is there pain? It's always worthwhile, if the person with autism is happy going to see a doctor and being examined, getting a general checkup and treat anything that's found. Pay close attention to any change of medication, including over-the-counter medications and supplements. Supplements and herbal remedies are not benign. They are not without their own side effects. So any changes there also need to be taken into account. Obviously, any changes in routine and environment can cause changes in worsening of behavior. Any recent trauma, which can include a change, for example, of a carer, and any psychiatric conditions. Okay. So yeah, just with the psychiatric conditions, I think I'm going to come back to this later, but it's quite difficult to actually diagnose psychiatric conditions in people with autism. Yeah, I think I will actually come to it with the next slide, but yeah, it's not an easy process, and it's important to actually get somebody who knows autism to do those diagnoses. So when does medication become necessary? Obviously, if they're medical conditions, these can include epilepsy, which can present as a behavioral change. Epilepsy is such a huge, can present in so many different ways. And it's important to screen out and make sure that that isn't an issue. It can often be screened out just by history taking, just actually seeing what the behavior is. but sometimes it will require things like an EEG, which can be very difficult in somebody with autism, because the moment you sedate them, if they need sedation, you're changing the EEG. So it's really not always an easy thing. Medication is also necessary if there are comorbid psychiatric conditions. You really do need to get a psychiatrist who's well versed in autism and who listens very carefully both to the carer, so the person who knows the person with autism well, and the person with autism if they're verbal, and who takes time to observe the person with autism, okay, to make an accurate diagnosis. Even with all of that, it can be very difficult. But people with autism are not immune to getting psychiatric diagnoses that are in the general population. The common conditions that we do find in autism are anxiety. Here you've got somebody who's trying to manage to live in a neurotypical world with all of their extra challenges, and it naturally causes a lot of anxiety. That's often actually present from an early age, but it can come in at any age. Depression. Depression is also very common in people with autism of all levels of functioning. That's, yeah, and again, in higher functioning, sorry, I don't like that term, but I'll just use it for ease of reference. In higher functioning people with autism, they can become depressed when they realize they are not the same as their siblings, as their cousins, as the people around them, and may not be able to attain the kind of goals they always saw for themselves in life. That can cause a lot of depression. ADHD, by definition, that's always present from childhood and may need intervention with medication. And then medication can also be necessary when people have high-frequency dangerous behaviors not responding to other interventions. So what I mean by that is that sometimes somebody with autism will have a meltdown and become aggressive, but it happens once a year, once every 6 months. I am always super reluctant to intervene with medication in that situation, because you're putting somebody on a medication that they're on chronically for a behavior that happens very, very seldom. But if it's a high frequency behavior, it happens.
Okay, so we'll go straight back to Judy. Sorry about that, everybody. Okay, thanks.
Okay.
Thank you for your patience.
Isn't technology great? So yeah, we've had the lights collapsing and then Zoom letting us down. Okay, well, Zoom just being mean. Okay, so psychiatric medications that are used in people with autism, or just psychiatric medications in autism. Firstly, it's important to say that sometimes medications, the usual medications that we use for everybody, work well and as expected in people with autism. And not everyone with autism has an unusual reaction to medication. However, it definitely is the case that people with autism are much more likely than neurotypical people to have what we call paradoxical reactions. So, for example, actually becoming more agitated with tranquilizers that we see quite often. The anti-epileptic medication Epilim can actually cause it's a sort of almost get a Parkinsonism-like or Parkinsonistic-like response, or they don't respond as would be expected, or they experience increased side effects. But generally, though, if someone is diagnosed with autism, is diagnosed with a psychiatric condition, start by using the same medications used for anybody else: antidepressants for anxiety and depression, mood stabilizers for bipolar disorder, and stimulants for ADHD, i.e. Ritalin in this country. Okay, then with the autism-specific problems, there are only 2 medications that are actually FDA approved, because they're the only people that have actually approved anything specifically for autism, that are specific to autism, and that's risperidone and aripiprazole. So they have a lot of other names, Abilify for aripiprazole, risperidone is Risperdal, those are the originals, and then there are a host of other generics, so you may well know them by other names. They are licensed for use for irritability in autism. They're both antipsychotic medications. They come with a host of potential side effects, but can actually be extremely effective both subjectively, in other words, to the person with autism, and objectively, in that the behavior is more socially acceptable. Then for those are the only ones that are actually licensed for specific use in autism. For what we call aberrant social behavior, so behaviors that are not socially acceptable, risperidone is the one that has shown the most efficacy. So in trials that have been done, that's been shown to be most effective. And then for repetitive behaviors, fluoxetine. Personally, my experience with it is that it's not particularly effective for repetitive behaviors, but it kind of depends on whether that repetitive behavior is a routine, whether it's OCD related, whether it is just a stim. That's what makes the difference as to whether it will respond or not. Okay, so that's a very brief little bit about psychiatric medications in autism. Herbal and other interventions, I wanted to just touch on this. It's not my area of expertise, and honestly, one can talk for hours on the subject. I do think I need to briefly touch on it, though, because it is very important, and I do get asked about it every time I see somebody with autism. It's important to know that there are very few studies in people with autism for these herbal remedies, and also a few studies in people generally for these herbal remedies. And most studies to date that have been done on autism have been done using mouse models of autism, and mice are not people. So we all know about the various dietary interventions. Ketogenic diet, that has definitely been proven to be of help in epilepsy, and sometimes has helped people with autism, just generally in terms of being less irritable, less moody, more amenable to change, less anxious. The gluten-free is very, very common, and there is a certain amount of evidence behind that. Sugar-free diets, preservative-free diets, very difficult to know what's going to work, and often one just simply has to try within the limits of what is acceptable to the person with autism as well. Green tea extracts, these actually have got some evidence. So you'll obviously go and find them in a health shop. They've been found to improve what is termed symptoms of autism. So I'm not quite sure exactly which symptoms they're referring to in the study, and definitely do work in anxiety. You need to be careful, so you need to stick to the doses that are recommended by the health shop, because high doses can actually be toxic to the liver. And then my favorite, cannabis or CBD oil. Everybody cannabis, especially up here in Plet. So yeah, the recommendation for use in autism is to use a cannabidiol to THC ratio of 20:1, or to use pure CBD oil. Studies are still really outstanding in terms of efficacy. And to be honest, cannabis is an extremely complex plant. There are something like 71 active compounds in it. So it's really, really difficult to kind of hone in on the right preparation for anybody. Pure CBD oil is often underwhelming in terms of its efficacy. One often does need some whole plant extracts, because I think a lot of the other constituents of cannabis are also important, but we actually really do not know enough about it yet. I have been learning, so as I say, I often learn from my patients. One of my patients was not autistic, but I really wanted to put him on an SSRI. He'd been depressed for a very long time, and his grandfather is an absolute one of these people who feels that cannabis fixes everything. So unfortunately, I couldn't get my patient to take any medication, but I have learned an awful lot about cannabis subsequently, because I've got the grandfather to send me all of his research. So that's been helpful. I've had very mixed reports. So I have had reports from some people that it's been absolutely brilliant, and from other people it's done absolutely nothing. I suppose in essence what we can say, as long as you're using predominantly CBD, it's unlikely to cause harm. You do have to worry. I would not suggest smoking cannabis. The high THC component it is definitely can cause paranoia, and can actually cause psychosis. Someone does have to be very careful, please. It's not a benign substance. Then piperine is found in black pepper. This is seen neuroprotective, and there are studies going on there. Resveratrol, is actually quite a lot of evidence that this is very effective, both in people with autism and neurotypical people, specifically for anxiety, but also for depression. Resveratrol is what's found in red wine. So it's also good for your heart. You don't have to give red wine. You can actually buy the resveratrol. It's also found in grapes, but you need to eat a lot, and in pine nuts and peanuts. Curcumin, bori, that is also a very useful substance, and there is some evidence there. Bacoside, it's an Ayurvedic medicine, so it's Bacopa monnieri. There are some studies there as being helpful in autism. And then ginkgo biloba is well known as a herb that helps with cognitive function. And there has been some evidence to show that that can be helpful in autism as well. Okay. So, yeah. In conclusion, basically, there's no medical treatment for autism per se. And I certainly have a lot of dealings with people who are very, very militant in terms of the fact that it's not people with autism that need to change, it's the environment that needs to be changed around them. But when there have been behaviors that are challenging, and I really do understand from both perspectives, you need to run through these things. You need to exclude and treat medical conditions, exclude and treat psychiatric conditions, try to understand the function of the behavior, use a low arousal approach where possible. In other words, again, try to understand the function of the behavior and reduce the stress, and medication if indicated or as a last resort. Okay, thank you. So that is me done. Okay, I just want to get you back there. There we go.
Okay, hi everybody. Sorry about the hiccup after yeah, in between that, and thanks for coming back in, Judy. Thanks very, very much. And
sorry.
These amazing slides and your talk. There, I had so many little questions lined up myself, and I think many answers were in your actually. Thank you.